Good evening, everybody. I'm Shamila Jasin. On behalf of the College of Biochemists of Sri Lanka, I welcome you today to our monthly webinar series. The College of Biochemists serves as academic and educational headquarters for biochemists and molecular biologists in Sri Lanka. And it is the official country representative to the Federation of Asia and Oceanian Biochemists and Molecular Biologists, the FAOBMB. The college serves as a platform bringing together biochemists and molecular biologists in Sri Lanka and abroad in the exchange of scientific ideas and knowledge, as well as training. So today's topic is emerging role of vitamin D in the prevention of COVID-19 by Dr. Sunil Wimalawansa, Professor of Medicine, Endocrinology and Nutrition from the Cardiometabolic and Endocrine Institute, New Jersey, USA. I'd like to invite my colleague, Dr. Sanat Mahalpanage, to introduce the speaker to you today.
Thank you very much, Dr. Shamila. Dr. Wimalawansa, MD, PhD, MBA, FACP, FACE, FRCP, FRCPET, and BSc is a professor of medicine, endocrinology, and nutrition. He started his career as a lecturer in biochemistry at the University of Peradeniya under the mentorship of late Professor T.W. Vikramanayake. Later, he proceeded to UK for his higher studies. Professor Wimalawansa has held various positions in various organizations. He was a consultant to the International Atomic Energy Authority and also served as a professor of physiology and integrative biology and pharmacology at the Graduate School of Biomedical Sciences in New Jersey, to name a few. He was awarded several investigator awards such as Annual Dr. Boy Frame Award for Clinical Excellence in Metabolic-Borne Diseases. His contribution to the field of life sciences is remarkable. In 1984, he invented the use of intraoperative hormone assays to assist in endocrine surgical procedures, now used by thousands of endocrinologists, surgeons globally as the standard of care. This is just one example. More than that, he is a kind of all-rounder. He is the first Sri Lankan to climb Himalayas, a retired Air Force squadron leader, and a philanthropist. He established his foundation called Wimalawansa Foundation to help poor people affected by CKDU, and one of the leading researchers in that perspective. Among the number of books that he has written and published, one of the books that I like most is titled All You Need to Know About Vitamin D. I think he is one of the most qualified individuals, scientists, to talk about this field. Over to you, Professor Sunil Wimalawansa.
Hello, thank you Dr. Jayasena and Mahavitanage for inviting me to give this presentation on emerging role of vitamin D in the prevention of COVID. Here I'm going to discuss about the basic aspects of definition of vitamin D, epidemiology, and basic biochemistry with reference to its generation and D2 versus D3 and consequences of hypovitaminosis D. The most part of my presentation will be focusing on the deficiency and relationship to COVID-19 and its clinical outcomes. In this presentation, I do not have any conflict of interest. The book mentioned by Dr. Mahavitanage is on vitamin D, All You Want to Know. And the second one, the biology, physiology, and pharmacology to vitamin D will be coming sometimes next year. So this is a book Dr. Mahavitanage mentioned. Importantly, vitamin D, or in North America it's called vitamin D, is an essential hormone. Without it, humans cannot survive. There are two basic metabolites of vitamin D, D2 and D3 of physiological concern. The D2 is a plant source, whereas the D3 is animal source. And there are two major differences of D2 and D3. Firstly, D2 has a shorter half-life compared to D3. And in D2, there is a double bond between C22 and 23 with the methyl group on C24. So for clinical point of view, D3 is the right or the proper human variety of D3 to be prescribed. So again, the difference between the D2 and D3 is half-life from a clinical point of view. Thereby, given the same dose, as you can see, D3 levels goes up quicker and maintain longer period because of the half-life is longer. So D3 is a natural form for human and indeed the preferred form for supplementation. So D3 is essential for survival. In addition, the major portion of the D3 requirement is supposed to be maintained or made in our skin following exposure to ultraviolet B rays in sunshine. In fact, now D3 deficiency is the most common vitamin D deficiency, but it's a very easy to rectify and costs so little. So assessing the vitamin D status, the measurement of serum 25D hydroxy level is the only way to form one. Do not measure 125 dihydroxy D, but measure, if you need it, only 25 hydroxy vitamin D level. So let's look at the biochemistry, physiology, and pharmacology of vitamin D, again related to today's presentation. Historically, humans obtained vitamin D through skin exposure to ultraviolet B rays from the sun in this particular UVB exposure range. It converted the 7-dehydroxycholesterol in the skin into pre-vitamin D and through a process called isomerization, and then the pre-vitamin D will be converted to D3 before it's transferred or transported through the binding to vitamin D binding protein into the liver. So in this diagram, I'm going to show you the generation of vitamin D from generated D3 from the skin, pre-vitamin D. Cholecalciferol is a human or the D3 version, and it converted to 25-hydroxy vitamin D in the liver and further hydroxylated in the kidneys, renal tubules into 1,25-dihydroxy vitamin D. It's the active hormonal form. It's also called calcitriol. And that's one leads to physiological effects or biological effects following its binding to its receptor. Similarly, the dietary intake of vitamin D, mostly D2, follow the same pathway and lead to similar biological effects. Since this is a biochemistry forum, I'm going to discuss a little bit more in detail about the biochemistry and the conversion and how it affects these cellular function. The precursor of vitamin D3, here the calcitriol is a calcidiol. It's called the 25-dihydroxy D. So it activated into calcitriol in the renal tubules, and this is the one has a hormonal action throughout the body. However, in target tissues, the intracellular generation of 1-alpha through alpha hydroxylation into calcitriol is the most important pathway where the immune and other system and the cells activated through intracellular generation of calcitriol. So this leads to paracrine and autocrine function, whereas the calcitriol generated in the renal tubules, it purely functions as an endocrine hormone. So that's two different aspects of calcitriol. The most common mineral deficiency in the world now, vitamin D, which has surpassed the iron deficiency and anemia. So it's very easy and economical to correct the vitamin D deficiency. In the absence, in the children can lead to rickets, the bowing bones, And in adults, it leads to osteomalacia, in Latin, is called softening of bone. The latter is also associated with uh, neuromuscular incoordination, therefore increased falls, osteoporosis, and fractures. Moreover, it also associated with many disorders, and I am going to summarize one in a couple of minutes later. For biochemistry and physiology point of view, there are major difference between the function or the absorption and the biological function of medications versus micronutrients. What you see in this green line is the how the drugs medication behave once they are administered to the oral route. As you see, it has a wider function of 3 orders of magnitude from here all the way to here, larger area of functioning with a gradual increase in the level, and the function is improved with that. This is in contrast to vitamin D, which is a threshold nutrient, similar to iodine and B12. So this threshold nutrient has a totally different way of biological acting. As you see, with reference to the vitamin D, it changed from 10 nanograms to 100 nanograms a ml, which is only 1 order of magnitude compared to the drug has a 3 orders of magnitude. So this narrow therapeutic range, you do develop or generate all the biological and physiological functions. If someone has adequate vitamin D level, giving further nutrients, similar with iodine, B12, will not generate any additional beneficial effects. It's a flat curve. Whereas when you have the deficiency, giving even the small amount can make a difference in physiological functions. So I'm going to present you with the several key the fundamental issues that you need to be aware of related to vitamin D. One is the differences of tissue and body systems needing to get the activity to the maximum. So in this slide, I've summarized the x-axis is the serum 24-hour vitamin D level in nanograms per mil in most of the slides. And on the right side, I'm showing that the alleviation of or improvement of disease condition. As you see, in mineralization or elevation of rickets and osteomalacia only need the 10 to 15 nanograms of vitamin D in circulation. It's very sensitive. Whereas, for example, alleviation of cardiovascular diseases and reducing all-cause mortality due to vitamin D deficiency, you need a much higher level, in this case almost 4 times higher blood level of vitamin D to overcome such disorder. So with reference to nutrient like vitamin D, one dose does not fit everyone. It's a dose dependent, and for example, like autoimmune diseases and cancer prevention, you need even higher level of vitamin D in the circulation. Moreover, it's a therapy with vitamin D or supplementation is highly cost effective. So here I have summarized in one sentence. The cost of correction of vitamin D deficiency is less than 0.001 of the cost of dealing with complication associated with vitamin D. For example, management of diabetes and its complication, obesity, metabolic syndrome, cancer, or cardiovascular diseases. In general, the mentioned disorders will cost anything from $5,000 to $15,000 per year per person in United States, and the similar but proportionately lower in other countries. Nevertheless, you can see that the replacement of vitamin D costs much less than that. Despite all this and the knowledge of over 60,000 research publications available in the internet, in science websites, vast majority of the population are still kept vitamin D deficient. So let's look at the prevalence of vitamin D insufficiency. At least we have from where I used to work in USA, and especially in the nursing homes and disability centers, vitamin D deficiency is amounting nearly 90% of their population. So you can see that this amount of vitamin deficiency, this is in spite of government mandated 400 units of vitamin D given to every person in nursing homes and disability centers. So that kind of doses, it's pediatrics and does not even touch in adult diseases. So the key reason for vitamin D deficiency globally is lack of exposure or failure to exposure to sunlight. And in COVID cases, that has led to more than 60 or 70% of the deaths associated with these viral diseases. For example, the deaths in nursing home residents could have been reduced by 70% by supplementing with vitamin D in the range of 4 to 5,000 a day. This had been prevented. Unfortunately, very few places, if at all, they acted properly. The combination of advancing age, poor health, and comorbid conditions, as mentioned, like diabetes, hypertension, cardiovascular disorders, and the vitamin D deficiency is detrimental for the health and well being of the elderly. So, I'm going to give you examples to summarizing the relationship between the low vitamin D and multiple other disorders like diabetes, obesity, and metabolic syndrome. So, all of you are aware of this common set of conditions, starting with the metabolic syndrome. That is a derangement of hormonal and metabolic functions. It can lead to diabetes, hyperlipidemia, hypertension, obesity, and indeed insulin resistance. Similarly, the insulin resistant diabetes, obesity can worsen the metabolic syndrome. However, most people doesn't understand is that vitamin D is underlying cause for worsening of most of these disorders and severity and complication. So all this can be minimized, not eliminated, by correcting the vitamin deficiency. That would not cost anything more than $7 to $8 per person per year. So let's look at the evidence supporting a relationship between COVID-19 and vitamin D. So that's a key part of our topic today. So what we're looking at is a causality of whether the vitamin D is related to COVID-19 and whether the death rates and complications are related to hypovitaminosis D. So in person with COVID-19, for each standard deviation increase of serum vitamin D level, the odds ratio of having a better outcome is increased by nearly 20 times, 20-fold, not 20%. So similarly, the opposite also true. When there's a decrease of one standard deviation, it increases the probability of complication and deaths by closer to 20-fold. You can see that the sharper part of this curve I showed about the threshold nutrient and the value of replacing this essential micronutrient. So in addition, the multiple observational data, I'm talking about a few hundred published reports or scientific data showing the positive association between vitamin D status and COVID-19 outcomes. Now, in addition, towards the end of my talk, I will going to discuss very briefly the hormonal system called renin-angiotensin system. So this is the one goes overactivated by the COVID-19 through indirect mechanism, which lead to massive production of cytokine, the chemicals in the body, leading to inflammation, oxidation, and so-called cytokine storm, leading to respiratory disorders and death. So what are the evidence that vitamin D causality to COVID-19? There are only a handful of clinical trials in this area published to date, because this is during still the first year of the manifestation of COVID-19. But today there are at least 50 very large statistically powered randomized control studies are available or the ongoing, and this data from these studies will begin to available from December onwards. Meanwhile, the majority of people admitted to ICUs, intensive care units, with COVID-19 are having severe hypovitamin D. Especially, the levels are less than 10 nanograms per ml. That by definition is a severe vitamin D deficiency. In addition, the higher incidence of COVID-19 related deaths occurring in the location where there is less sunshine, northern latitude, so as the southernmost latitude during the winter time. Common feature is these countries have a lower ultraviolet B radiance. Therefore, the people, especially during the winter time, has the least amount of vitamin D, and half the population become severely vitamin D deficient. In this case, respiratory viruses, as again I will touch later, have higher chances of infecting people and causing complication and deaths, just as what we saw with influenza over each year and through COVID-19 during the winter 2020, and similar things going to happen in 2021. And those with darker skin color individual will have a disproportionately impact by COVID-19 mortality, especially if they are living in the temperate climatic countries like the UK and northern part of United States. So in addition, the both observational and randomized controlled studies published to date on COVID and vitamin D reported the significant inverse correlation of 24-hydroxyvitamin D level in the blood and COVID-19 risk, severity, and indeed deaths. So this important bit of information you need to remember. In general, when the person having less than 10 nanograms per mil of 24-hydroxyvitamin D, which by definition is severe hypovitaminosis D, the death rates are extremely high. In the interim, having less vitamin D between 11 and 20 nanograms per mil have a severe disease, but they will recover. Whereas those with moderate disease have a less complication, and those with the higher levels, about 30, and the vast majority, I'm talking about more than 95% of them, do not have any symptoms. They become asymptomatic, sometimes a carrier of the disease as well. So those having the serum vitamin D concentration less than 12 nanograms per mil are likely to have a 14.7 times die from the disease once they get infected. In this study, survival graph, we show that the survival probability in the y-axis and the duration on the x-axis. So what you are looking at here is the study published from Germany. It showed that the 185 patients with the probability or the p-value of 0.001, certainty shows that the likelihood of dying from vitamin D concentration less than 12 nanograms is significantly higher. So another way to looking at it, the European map showing the percentage of population who are less than 10 nanograms per mil. In the y-axis, what you're looking at is the deaths per million from COVID-19. So all those countries with a higher percentage of people with the vitamin D deficiency has a very high death rate from vitamin D deficiency. This is another way of looking at the vitamin D deficiency association with COVID-19. Here are a few the key factors of biology and physiology of vitamin D has forgotten, and in fact many doesn't even aware of. So presence of hypomagnesemia actually reduce the efficacy of vitamin D significantly. This is also true for most of the hormone, even those who are dealing with this are not aware of. For example, the insulin, thyroid hormones, and specifically the parathyroid hormone actions are markedly reduced in the presence of hypomagnesium. Low vitamin magnesium level in the blood will prevent the release of these hormones and thereby its beneficial effects. Secondly, the effectiveness of the vitamin D and the receptor interaction, where all the gene activation occurs following that through the second messenger systems. If you look at the immune system, in particular related to the COVID-19, can be enhanced with additional micronutrient intakes and sufficiency. So this is in addition to vitamin D. We are talking about the vitamin K2 and a small amount of vitamin A and C, but more importantly, magnesium, zinc, selenium, omega-3 fatty acid, as well as quercetin and resveratrol and similar micronutrients. So in the presence of adequacy of vitamin and all these vitamin and micronutrients, one would expect to have the best outcome from COVID-19. So this is a slide just to show how long it will take to develop, generate the serum level, as you saw in the y-axis, against the duration on the x-axis. When you give the doses like 400, 1,000 or even the 2,000 international units of vitamin D per day, it takes about 12 to 18 months even to come the plateau of their serum level of vitamin D. This is actually in part due to because most of the stuff we get through the diet and the supplementation will go to the storage in the fatty and also don't forget in the muscle tissue. So vitamin D's are stored quite a lot. So before the vitamin 25-hydroxy elevates in the blood, it has to saturate these first vitamin D stores. That's why it takes this long to replenish serum levels. This is also true even if you take the 4,000 international units per day, it takes about 14 to 16 months to achieve a plateau of getting closer to 40 nanograms a mil. This is a good dose. But during which time the person may not be protected as one would expect. So way to avoid that is actually to anybody with vitamin D deficiency in particular, and also it can be done same with the vitamin D insufficiency, administration what I call is upfront loading dose of vitamin D. It could be anything from 100,000 to 600,000 to rapidly boost their vitamin D serum level because it can saturate these vitamin D stores in the body very quickly, and thereby the levels will go up rapidly, and that can be maintained with the maintenance dose of something like 4,000 interaction units per day to maintain between 30 and 60 nanograms per mil. So one could also administer the weekly doses of serum, in this case, either 5,000 units daily or 50,000 units once a week. You can actually achieve the maintenance dose or the maintenance level of desired level of vitamin D in the blood or in nanograms per mil within relatively rapidly. Here's an example what happened when you give loading dose or higher dose of vitamin D, like in this case 200,000 as a single dose, which we commonly had been using in outpatient practices for last 20 plus years in a routinely manner. Because when you do that, the patient level will goes up within 2 days, maximum 4 days, and the immune and other system will get benefited by from day 3 onwards. So you get a very rapid action and benefits from this micronutrient converted into the hormone. However, also note that if you don't give a daily supplementation, this level is going to go down because the half-life is only about 3 weeks. So by the time the 30 to 45 days, the level is going to come back towards what it was before. So this decay of vitamin D, depending on the dose, if you give a higher dose like 600,000, is going to last about 20 weeks plus. So if you give the 100,000, it will only last about 4 weeks. So it depends on the situation. I'll come back to that again. You need to identify the right doses to be administered. So achieving and maintain the optimal serum 24-hydroxy concentration in most of us believe is between 30 and 60 nanograms per ml will prevent multiple diseases and disorders, at least 40 plus different ailments. The goal for those who are with the comorbid condition particularly during this COVID-19 era, is to maintain this 24-hydroxy vitamin D level between 40 and 60 nanograms per ml. This has a particular biological reason, as this comorbid condition, most of them are going to need a higher baseline level of vitamin D to overcome COVID-19 associated complications. So it's much safer for elderly and the disease condition which I mentioned at the beginning, for them to have a higher level of serum vitamin D in the range of 40 and 60 nanograms per ml. So it's another smaller study, but it's proved the point that when somebody is having the vitamin D level 30 nanograms per ml and above, the COVID-19 cases per million or the death rates become closer to zero. So virtually 98% of the people who are dying from COVID-19 has hypovitamin D, and this range is actually nanomoles per liter. So to convert this to nanograms, you need to divide this number by 2.5. Well, here the 75 nanomoles per liter is equivalent to 30 nanograms per ml. The important thing to remember is that the levels are lower, your death risk of dying from COVID-19 is high. So this is a study published early this week. It showed that 5 times reduction of the intensive care unit admissions if those who are taking supplements. So 5% of the people who are taking some supplements versus 25% of that particular group are not taking supplements. So the huge difference. Similarly, there was a length of hospital stay was reduced by 4 days, which is almost like a 40% reduction of length of stay, which is a huge thing on hospital cost and complication associated with the hospital stay. So what are the additional research data, recent data on COVID-19 and vitamin D? This is a slide created from India, actually many months ago, and similar data is available, but I deliberately use this one which is very clear. The 2 points I want to mention using this slide is to see that the people above 60 years had the largest number of deaths, and in fact, the 63% of people who died in this group of 4,281, they were above 60. Nevertheless, the vast majority of the people got infected. Almost like 80% of them were under the age 60. But as you know, the death rates are much lower, especially in the younger. Death rates are talking about 0.1% or less death rate, because they don't have the multiple comorbid conditions and their immune systems are reasonably good. Second point is that there's a male to female ratio varies from 1.7 to up to about 3 times. Males are more susceptible to develop complication and dying from it through COVID. There are multiple reasons, biological and physiological, to explain that, which I don't have time today to. It's a different topic, but there is a biological explanation why males are dying faster than females. This slide summarizes the effects of the latitude of where they live, the northernmost or southernmost part of the country of the world, and the mortality from COVID-19. Here you are looking at the y-axis is the mortality per million population, whereas the degree of the latitude where people live. So as you see that living away from the equator, the two ends, the death rates are much higher. You're talking about exponential increase of complication and deaths. So what's a common factor? Is exposure to sunlight. Those who are around the equator get continuously exposed to sunshine more than 300, 340 days a year. Therefore, they have some degree of vitamin D levels in their blood, and they are partially protected from developing complications and death. And Sri Lanka and uh, other Southeast Asian country located here. The only exception is India. I mention that again because the India death and complications are due to multiple different reasons. So let's get an example of effect of mass gathering of people without taking proper precaution, particularly not wearing face masks. Here's the data published from US on June 25th. It's a specific holiday. It's a big holiday in US called Memorial Day, where you can see the 3 days of festivity. Millions of people came to street and enjoyed and without mask and no social distancing. And 2 weeks later, you can see that the almost doubling of the new cases of COVID-19 reached closer to 48,000 per day. You can see the effects of lack of social distancing and not wearing masks. So the basic public health principle of what happened. So to highlight this, I put this slide for you to look at the 3 pillars of basic public health measures everyone should adhere to. First and most important thing is using the proper effective face mask, because more than 80% of the time COVID is actually transmitted to another person through inhalation, not by any other means. So the microdroplets is a predominant cause of inflammation, not the macrodroplet as some claim. And these microdroplets can float in the air because they're smaller size and density up to about 20 meters. So in a room, somebody with a COVID-19 sneezing from the bottom at the behind of the last row, the people in the entire room can get exposed and get infection, especially that person has a very high concentration of virus, as what you call it, the super spreaders. So keeping the social distance of 2 meters will not help in that circumstance in the presence of a super spreader in that community. Secondly, about almost like 5% to under 10% of the infections are due to contamination of the fingers through the large droplets deposited on surfaces, smooth surfaces like stainless steel or tabletops or glass. When you touch, your fingers get contaminated, and if you touch any mucous membranes like eyes, nose, mouth, etc., it can transmit directly to yourself, what you call the self-transmission. Here's the effect of lack of social distancing, which is obvious. So now let's look at the relationship between serum 25-hydroxyvitamin D concentration and death rates from COVID. I'm going to show a series of slides to illustrate this important point. Now we are looking at is a percentage death rate for survival and the vitamin D concentration in the blood in nanograms per mil. As you see, with the death rate markedly decreases when the people having the higher serum concentration of vitamin D. Around the 29, 30 nanograms per mil of vitamin D in the blood, death rate dramatically drops virtually near zero. In this particular study, there's no difference in the age group what we are looking at. So this is an age-independent factor. It's serum 25-hydroxyvitamin D effects on a reduction of death dramatically. So there's another aspect is a lot of people are worried about this skin color. The darker the skin color, lesser the amount of vitamin D can be produced in the skin. So darker skinned people like black, non-Hispanics, Hispanics, and Asians like us, living in temperate countries like in northern part of the UK, USA, or Mongolia, or northern China, there's a very high risk of developing COVID-19 and getting complications and death from it. So this is true whether you're having the serum concentration of 20. You can see that the doubling of death rates of people with darker skin color. Similarly, with even at the vitamin D concentration at a higher level, you still see the difference between the two ethnic groups. So, the seropositivity indicates that blacks and Hispanics have a higher COVID-19 rate than whites. So, one could argue that if blacks, Hispanics, and people with the brown skin color, if you can increase their serum 24 hydroxy concentration above 30 nanograms per mil, what I call the population vitamin D sufficiency through supplementation or health advice to save sun exposure, they could reduce a seropositivity, that is infectivity, and indeed deaths by about 40%. Very, very cost effective way of handling this rather than spending millions and millions of your own currency to quarantine centers, curfews, and developing and building intensive care units all have become redundant and absolute waste of money and resources. This is a study, it's not published, but it's in the website by Dr. David Grimes. He's a senior physician from the UK, and to point show the point that the effect of the people with a darker skin color, so-called BME, the ethnic minority group, has in this case. So he used the group of doctors who died in UK because that's unique reason for this, because they are whether you're white, black, or brown, the social class is the same. They live in the same environment. Their cultural and other habits are generally similar. So you are actually eliminating most of the confounders like socioeconomic status in this particular group of people. As you see, the mean death rate, mean age of the white doctors who died in UK is about 90. Many of them are retired. Whereas with the mean death rate of the people with the colored skin, the death rate is about 60. So what you see is about a 30% decrease in age. So these people are dying at a 30 years younger than the white counterparts. So this increased death rates in UK compared to the white doctors who died suggests that importance of having at least indirectly informed us that this is due to vitamin D, severe vitamin D deficiency in this group of people. So there's another study from UK highlighting the total registered hospital deaths here on the y-axis and the various ethnic groups they have categorized. Again, you can see that the highest death rates are from the people with the black Caribbean. Anyway, the darker the skin color, higher the death rate, because these people are not generating enough vitamin D even for the basic necessities when they move to the northern latitude countries. So they are highly vulnerable to develop respiratory infections, specifically COVID-19, that need the vitamin D adequacy to help maintain the health and prevention of death. This is another study published by Kaufman et al. Recently in September, showing that there's a 40% less death rate in infected with those who are infected with the higher serum concentration. So you can see here, people with higher serum concentration, the infectivity or the PCR positive rates are much, much, much less. So another study to show the severity of the disease, as you show in the x-axis, and the probability of getting the disease. For example, the people with a mild COVID or is asymptomatic, some of them are carrier, have a 95% of the probability they are having the normal vitamin D levels. Whereas those with a severe complication or critically ill in the intensive care units, there's a 95 probability that these people will have a severe vitamin D deficiency. So it's a no-brainer, but these people should be treated with the high dose, what I call the loading doses of vitamin D, which can save their lives in a large number of people in the intensive care unit. So similarly, there's another way of looking at it is where the people live, the northern latitude versus closer to the equator, and the southern latitude. But this is during December through April, therefore the winter time in the northern, and southern latitude is the summer. Therefore, it's very similar to those who are living around the equator. You can see that's a big difference between almost doubling of the PCR positive rate in those who are living far away from the equator, therefore during their winter time. Almost can see that level actually double at irrespective of the serum 24-hydroxyvitamin D level. So there are other factors which affecting the complication, acquiring the disease, and death from COVID-19. So I'm going to show you two slides to summarize the actions or the mechanism of vitamin D in protecting from COVID complication and death. Here, only to show this green area, which shows the whole kind of alphabetic soup, which basically show in the various chemicals generated or suppressed, in this case, in the immune system only. You can see that the large number of these chemicals will be altered in the presence of vitamin D deficiency in a very, very negative way. When you have the vitamin D adequacy, this whole thing becomes positive. With reference to the effect on the respiratory tract, vitamin D reduces the acute respiratory tract infection, inflammatory and oxidative process becomes significantly less, and the exacerbation of asthma, COPD, even things like multiple sclerosis uh, reduce the incidence and exacerbation and certainly improve the lung function. Here's what I would like you to remember on benefits of vitamin D in controlling COVID-19. It stimulates all immune cells, especially the innate and adaptive immune system. Innate immune system is the one to become activated immediately following any type of infection, whether it's a parasitic, bacterial, or viral infection. Adaptive, adaptive immunity kick off later, about 7 to 8 days, and that has last much longer duration. Whereas innate immunity is like a sudden action to prevent infection get hold of your body. So vitamin D is also a potent anti-inflammatory and antioxidative effect, and it has multiple antimicrobial properties against viruses and bacteria. And indeed, vitamin D prevents cytokine storm, which is due to the massive release of series of chemicals called cytokine, and thereby prevent cytokine storm, lung damage, and death. In addition, the vitamin D also stimulate the production of neutralizing antibodies, and indeed the compound called is angiotensin converting enzyme 2. It's an enzyme, but it's also a receptor for COVID-19. The production of these two are essential to neutralizing and removal of COVID-19 and any coronaviruses from the circulation. They can neutralize and destroy it, take it to the macrophage cells, and those cells will destroy those viruses. So this is a kind of complicated slide, but since this video is going to be available in the YouTube, you can see this leisurely on the effect of innate immunity in the top half and the adaptive immunity on the bottom half, how the multi-system functional benefits from vitamin D. This is only one system, which is the immune system stimulation in a positive way. So because of that, I'm not going to go through details, but I will leave that for you to have a look at it. You can post the YouTube video at this place and you can watch that, go through details. So I'm going to change the topic to another interesting area. Why prevalence and death rates reported from tropical countries are so low? You're talking about 5 per million in the tropical countries compared to 800 to 1,000 per million in temperate countries. So there must be some logistical or other reason for having such a difference, a vast difference of death rates and the infection rate in tropical countries. For most tropical countries reported this unrealistically low rate. Question is why? There are two major reasons. One is these countries carry out less than 3% of the PCR, polymerase chain reaction test, to diagnose those with the viral antigen than is supposed to. So when you do the 3 or 4, 5% of the test, what you are supposed to do, as in Sri Lanka and India and most other South Asian countries, you can only diagnose that amount of people in the community. And in fact, these countries will never did the community testing until end of October. So what these countries reported are few spuriously low and significantly low because they are not detecting anyone with the COVID-19 infection in the community. All this reported data was based on either hospital or sometimes from quarantine centers. So lesser the number of testing carried out, lesser the diagnosis of COVID. Therefore, the reported death rates are so low. In fact, until end of October, Sri Lanka, for example, did not carry out the COVID-19 testing in the elderly, most of the elderly dying or people who died especially in the peripheral hospital. So none of them were included in those statistics. Fortunately, that has changed that attitude from end of October, and therefore you can see that the rate has gone up quite a bit since then. And the second most important thing for low rates are due to the exposure to sunlight, which is 300 plus days sunshine is available in tropical countries, and whether people like it or not, they get some exposure to sunlight, thereby developing some vitamin D, which enough to just manage to prevent complication and death. So to show this important point, I'm going to show this couple of slides. Here's the Northern Europe, the summarized data from 2010 to 2018. What you're looking at is the about 95 to 98% of all respiratory viral infection occurring through December to mid-April each year. So this is exactly the peak of winter when there's less sunshine and therefore less amount of vitamin D, and the best time for viruses to thrive and multiply more. So this slide shows that second point. In the presence of low temperature, low UVB index, and drier weather condition in light blue color, viruses are thriving. Their viability increases, their infectivity increases, and the viral load dramatically goes up among these three conditions. Again, these three conditions do not exist in tropical countries and therefore not a factor. So the misleading statistics provided to the WHO from these countries, with the exception of India, is mostly due to the absence of testing, community testing, PCR testing, and antibody testing, or even rapid antigen testing in these countries. So based on the large number of community studies done, it has been estimated that between 10 and 40 COVID-infected persons are present in the community. 95% plus of them are asymptomatic. So they are not being diagnosed and not included in the COVID statistics in tropical countries. For example, when the Sri Lanka is doing 500, now about 10,000 PCR a day, United States is doing between 500,000 to 800,000 COVID PCR testing each day. So you can see when you converted the million population basis, Sri Lanka is still carrying out only about 8 to 10% of the tests that need to be done, even with the 10,000 tests as currently done. So to assess the true number of people who are PCR positive, that means may have been infected, reported prevalence must be multiplied by an average factor of 20. So you know the number of people reported with PCR in your country, and you can multiply by 20 to get an estimated number of people who are infected, mostly asymptomatic, in the community. Some of them can spread the disease, some do not. So combination of these two key factors are the reason for the statistics of providing the misleading low numbers of COVID infection and deaths from these countries. Some people have asked the question that does medical care responsible for the prevalence of COVID-19? Answer is absolutely no. Let me give you an example for Southeast Asian countries. And again, I'm not going to read the slide, and you can read this leisurely. So there's up to about 60-fold difference in the number of hospital ICU beds and other healthcare parameters to show good and bad healthcare system in the South Asian countries. So when you compare with Bangladesh and Singapore, all this will applicable. Sri Lanka, India, Malaysia comes in between. The point is, except for India, which has, as I said, has a different reason for high death rates, all other countries, the South Asian countries, had reported very, very low PCR positivity and death rates, irrespective of the huge difference on the healthcare availability and delivery from good to bad. So healthcare really has nothing to do with the infectivity, no generally the death rate, except for the few people, less than 3% of the people who get admitted to the intensive care units. This vast majority of people will get better whether they are treated, non-treated, or do whatever the other people want to do. The people are going to get better on their own. So this slide, again, I'm going to leave it for you to read leisurely in the YouTube. You can post there and have a look at it. It summarizes all the factors in the tropical countries where you live and the erroneously misleading COVID-19 statistics reported by WHO. But these are the factors affecting so that low numbers, which is not realistic, but that's what they had developed and found, and they were reporting to the WHO. So let's move on to the next area to summarizing the reason for very low prevalence of and the death rate in tropical countries. Again, for two reasons, although there are multiple other reasons in the previous slide you can go through. The low prevalence of COVID-19 and low deaths reported are simply due to either logistical or natural reason. Logistical is you don't do number of PCR tests, therefore you don't diagnose. Natural is the availability of sunshine and reasonable immune systems. So low number of PCR testing and reasonable population vitamin D levels are the one responsible for low reported numbers. Nothing whatsoever to do with the curfews, lockdowns, or any form of healthcare intervention or any governmental actions. The right way to present the basic statistics related to public health, in this case PCR test and the death rate from COVID, is presented in this slide. So you need to convert that into a rates. Presenting the raw numbers as happening in the TV and radio on the daily basis is pathetic and absolutely wrong and misleading. So the number of PCR tests, positive tests, should be divided by the total number of PCR tests carried out. Whether it's in a day, a period, like a week, that's okay. And then you multiply by 100 to generate the rate. So that basically you standardizing the number of tests versus the PCR positivity so that one can compare within your own country or compare with the other countries. Similarly, the death rates from COVID-19 should be reported. COVID-19 related deaths divided by the total number of COVID infected people in the country, entire total number, multiplied by the 100. So this is the right way to do that. Should never ever present the raw PCR positive patients and this and that, which is totally misleading, and unfortunately annoyingly continuing every day. So the curfew was, unfortunately, this October curfew was based on the increasing number of positive PCR tests, and they forgot to look at the rate of change, which was no different from May, June, July to October. So they miscalculated, those who made the decision miscalculate the true incidence of COVID-19 and, and enforced yet another totally unnecessary curfew, causing further trouble for people and the economy. So if you do the calculation, basic calculation, the rate change from April, May, June was 2% to current October, November is 3%. So there's no statistically different or exponential growth of virus or spread of the virus. This 1% change was fully accounted by the increased number of PCR. In fact, it increased by 20-fold from 500 to 10,000. And testing in the community for the first time in high-risk population. In fact, I was surprised that even only 3%, I was expected to go up even higher. Nevertheless, the point is there's no significant difference of the positivity rate from early part of this year to now, October, November. So this erroneous judgment of basic statistics led to the enforcement of yet another unnecessary curfew. So whether there's incidence, prevalence, severity, that is ICU bed occupancy, or deaths, the number must be presented as a rate, percentage, or at least as a PCR positive person per million population basis, so that it is meaningful and comparable, and you can look at the changing within your own country. The raw data must be standardized as a rate, as mentioned in the previous slides, and presented to the public and to the WHO. So I'm going to present you only two slides on medication and vaccines, because that's not what my interests are, neither the public. Interest should be on the disease prevention, and the time and effort should be diverted to the prevention of the disease rather than using expensive medication and vaccines, which is a worthless effort. So, except for the hydroxyquinoline, there are no other cost-effective pharmacological agent available to treat COVID-19. Again, the hydroxychloroquine is a different story. It was shown that it's highly effective if you use a standard dose in early part of the disease, not the person who admitted to ICUs. It does not work. And it has a tremendous effect of disease prevention, prophylactically, or early stages of COVID. Yet, due to conflict of interest from big pharma and funders of pharma, it has been discredited for no apparent reasons. Some people are claiming it has a very high adverse effect, which is absolutely not true. Tropical countries like Sri Lanka, India had been using hydroxychloroquine for 5 or 6 decades as a control malaria. And even in the West, the hydroxychloroquine is freely used for immunological disorders for the past 40 years. So the creation of stories that hydroxychloroquine causes heart blocks and all these things is really to prevent people using the cheaper agents like hydroxychloroquine, and those people who are making these claims want them to sell the expensive antiviral drugs, which I'm not even going to mention in this presentation. So this is true irrespective of the type of medical system in your country, whether it's a Western, Eastern, Unani, Ayurvedic, or any hybrid system. None of these systems can eradicate the virus once the virus enters into your system. Similarly, the people who get infected with the virus, there's absolutely no way he or she can get rid of the virus by doing all kind of gimmicks like steaming, salt water, increasing body temperature, or whatever. Is not going to be effective. So don't waste your time and money and also put your life in danger by trying to change your body temperature and all this nonsense which has nothing to do with COVID control. So only thing what you can do is to stay in the sunshine or take some micronutrient supplements to boost your immune system. That is the only way that your body can fight against the COVID-19 and you do not develop any complication or death. In fact, in my opinion, the use of high dose of vitamin D, which costs less than $5 to $8 per person, is likely to be much more effective than any COVID-19 vaccine. And indeed, it has got a zero probability of complication compared to vaccine, which has a significantly high morbidity with the coronaviral vaccines. So if you look at the big picture now, if you look at the postulated defense against COVID-19, there are vaccines coming up, antiviral therapies, they are very expensive, and nothing in between practically one you could use to overcome the problem, except boosting the immune system with sunshine and vitamin D, which can prevent all these complications happening, particularly the cytokine storm, and get out of the ICUs with a full recovery. In the absence of adequate amount of vitamin D, the death rates, as I showed in previous slide, is going to be skyrocketed. So the single slide on vaccines in my comments. Despite all these hypes and false propaganda by various companies and people who are funding the vaccine, and indeed some governments, uh, desperately trying to bending backwards to purchase or to get donation of this vaccine, they're absolutely wrong. Firstly, it's expensive and unaffordable affordable for the majority of the population. So, to whom are these companies offering vaccines? The rich and the elite and the politicians, or the common people like you and I who cannot afford to have these vaccines? So, they're not protecting the world with so-called COVID-19 vaccine. There are multiple safety issues and already shown that people are developing serious adverse effects and in some cases even death following the vaccine. It's a single dose. Unfortunately, most of these vaccine needs at least 2 doses with weeks apart. So that adds to expenses plus some more side effects. Its effectiveness, what you call adaptive immunity, may not even last beyond few months. This we are not sure, but based on some people who had COVID-19 infection earlier this year and getting reinfected, suggests that this adaptive immunity may have some issues, and that's why some people, but smaller numbers, are getting reinfected. So, if this is the case, you're going to need repeated doses in years to come. This again causes expenses and serious adverse effects and possibly death. And one of the most important thing actually to many of these new COVID-19 vaccines need to be frozen at minus 70 and that kind of thing during the transportation and storage. And the vast majority of the countries in the world do not have such capacity. Again, my question, if that's the case, to whom these companies like Pfizer and others developing this vaccine for? So what I call is a fool's paradise for rushing to jump by administrations and countries to any coronavirus vaccine, particularly the COVID-19 vaccine, whether it's with the free donation or purchases. They need to think 3 times before making that decision, which may not be for the benefit of the country. And especially as some believe that the coronavirus epidemic, actually pandemic, is already getting over by early next year, then why we are subjecting people to harmful vaccines, which effects mean the negative effects could last forever in this paper. So dangers associated to vaccine, COVID-19 vaccines are too high to subject the population to it. compared to potential benefits, not knowing these adverse effects, benefits, and indeed associated costs. So I'm going to show you two slides on the currently registered ongoing vitamin D COVID-19 randomized controlled clinical trials. These two slides are from the vitamin D wiki run by my friend Henry Laho. Uh, this is the very early studies, I think in the May or June. That time had 18 larger studies. You can see that number of patients varies from 60 to 3,000, and so many of them are still underway. In fact, there was a study in Sri Lanka using 400,000 in quarantine centers in 2,000 subjects, which was completely sponsored and not at the cost of the government. But unfortunately, the approval was not yet given to that study. So by the end of August, September, there was some 34 registered studies in the NIH.gov website. Right now is something like either 49 or 50 studies had been registered. These are very large studies, as you see, with the 3,000, sometimes 27,000, and large number of patients have been recruited for these studies, and results of which will be available, starting to be available from December onwards, early next year. So let's look at how does vitamin D adequacy protects human from coronaviruses, very briefly. And we also touch a few mechanisms and how calcitriol blocks the coronavirus entry into the human system. So adequate vitamin D levels, I showed you multiple times in the previous studies, have been shown to be associated with a reduced incidence and, more importantly, the complication and deaths from multiple coronaviral diseases, including SARS and MERS. And in addition, the vitamin D sufficiency will reduce the severity and the chance of getting infected with the herpes, Epstein-Barr virus, hepatitis, Ebola, HIV, dengue, measles, and mumps. So all these viral disorders will respond to having adequate vitamin D level. So overall, there are multiple benefits. So this cartoon summarizes the cause of death from coronavirus 19 as we knew 3-4 months ago. So coronaviruses, particularly COVID-19, enter through the so-called ACE2 receptors, angiotensin converting enzyme 2 receptors, predominantly through lungs, but also through mucous membranes and the gastrointestinal tract. It causes acute lung injury in the absence of having good immune system. It can also stimulate the renin-angiotensin hormonal system, which further exacerbate the lung injury and the cytokine storm. So this causes the pulmonary hypertension, edema, and microvascular disease, especially a small vessel disease with microthrombosis and embolism into lungs, which added to acute respiratory distress syndrome and deaths due to this, and as well as pneumonia. So this is a busy slide. I'm going to spend a couple of minutes to explain it. It's showing the vitamin D adequacy. This is 125-dioxy-D, is a calcitriol. When you have the adequate level, it suppresses renin, thereby suppresses angiotensin 2, which is the most potent vasodilator and also one of the key factors pushing the cytokine storm. So this axis is suppressed with vitamin D. In addition, vitamin D suppresses the coronavirus specific pathways also. Coronavirus reduces the ACE2, that's blocked by vitamin D. Similarly, there's direct action of calcitriol or prevention of dissemination of coronavirus within human body. So furthermore, so when you suppress the cytokine storm through vitamin D adequacy, it stops or prevents virtually totally acute respiratory distress syndrome, so-called ARDS, pulmonary edema, hypertension, complication, and death. In the sideline, we also see that a lot of millions of people in the world are taking angiotensin converting enzyme inhibitors and angiotensin receptor blockers for hypertension control and protection of the kidneys. So as you see that these two agents also reduce the level of angiotensin 2 and thereby the production of cytokine. Therefore, it may have a peripheral role in benefiting people who are already on ACE inhibitors and ARBs, and they should not stop taking those drugs because that can be beneficial. So let me put a summary on the conceptual diagram of coronavirus. So since from the virus entry, vitamin D can prevent entry and activation of these receptors or the blockage of entry of the virus, as well as reducing the production of angiotensin 2 from this hormonal system. ACE inhibitors and ARB blockers I already mentioned in the previous slide. And the new medication could fit into the latter part with the people who are developing complications, and absolutely no reason whatsoever to give this expensive medication with the serious adverse effect in the early part of the disease with the people without complication. That's I'm also referring to dexamethasone, which can actually aggravate the situation if you give it to the wrong people, the 80, 90% of the people who does not require any of these medication at this time. So let me summarize now the COVID-19 vitamin D story. Those with 24-hydroxy vitamin D concentration above 40 nanograms per ml rarely contract COVID-19. Even if they contract, they'll be 98% will be asymptomatic. Most industries will continue to get affected from the COVID-19 epidemic, which could become a pandemic, which will become an epidemic early next year. This includes the airline industry, oil corporations, automobiles, banking, tourism, hotel industry, and all supply chains. Thus, most of the production has been affected. For these are get worse affected in the countries which inappropriately use curfews and state or a large area of lockdown. Lockdown should be used in a very small for geographical region to prevent the disease spread and never ever to use larger scale uh, curfews or even lockdown in the districts or statewide or the countrywide. It actually significantly counterproductive in affecting negatively the people and indeed for downfall of the economy. So in addition to the public health guidelines, following those, the recommendation for the high risk groups are as follows. So let me explain what are the three high risk groups I'm talking about. Firstly, the frontline workers like healthcare workers, contract tracers like army, law enforcement, police, etc. And anyone dealing with COVID-19 patient, including the social services and the public health inspectors, etc. Second group is the public who are at greatest risk of COVID-19. They are the elderly, those with the diabetes, obesity, any chronic diseases, especially the cardiovascular, pulmonary, and kidney. And then those who are with the high social contacts. And the last category is for those who with the recently identified as PCR positive. Some of them could be falsely positive, some will be falsely negative based on the quality of the PCR testing, and indeed the COVID-19 seropositive people. So these three categories, we strongly recommend you to taking action to provide them with the high dose, single dose, upfront vitamin D in the range from 100,000 to 400,000 international unit as a stat dose, one-time dose, which can be repeated after 10 to 14 weeks. So the goal is to rapidly increase serum 24-hydroxy vitamin D concentration that will within a day or two start boosting the immune system so that the people themselves have developed the strength of fighting COVID-19 and come out of it. That's the best and the only way people can get over COVID-19. So giving this high dose upfront loading vitamin D should be followed by taking either 4,000 or 5,000 international units of vitamin D, depending on the availability of the capsules, or one could try also 50,000 international use capsule. In India is 60,000 per week, or repeat the above high dose of vitamin D on a 8 to 16 to 18 weeks intervals as appropriate. No adverse effects have been reported with this above mentioned high dose vitamin D regimens supplementation to date, especially with reference to COVID-19 therapy. So this is a slide created by one of our colleagues, Henry Laho, on the vitamin D wiki. He created this as a body armor concept for military. For example, one could give a vitamin D 100,000 unit once a month, or 400,000 unit every once in 4 months, to keep them healthy and preventing getting infected with COVID. And at the same time, you have a contingency group here, as is shown here, reserves in companies with the boosting doses intermittently so that they can exchange with, for example, the army or police law enforcement agency on a strategic basis to have a healthy force available to do whatever the country needs. So this is the strategy called use the vitamin D as a body armor to protect COVID-19 from 19. So if you're interested in additional reading of the dosing regimens available, one could go to this website, viewmedi.com. There's a good article from my colleague about the doses vitamin D protect us from COVID-19. What's the required dose? So it varies from country to country, from ethnic groups, and I strongly urge you to go through some of these public websites and publications. So in summary, I mentioned that taking 4,000 international units of vitamin D will maintain healthy level of serum 25 hydroxy D in 98% of the people and maintaining a good immune system. However, in immune emergencies like in COVID-19, it is necessary and wise to administer loading doses between 100,000 and 600,000 in some countries to rapidly boost the immune system. These are life-saving measures and not gimmicks as antiviral drugs and vaccines. So these large doses should be followed up with the daily maintenance dose between 200 and 5,000, 2,000, 5,000 units, preferably standard dose of about 4,000 units of oral vitamin D on a daily basis, with preferably with sun exposure. These strategies will save lives, save economy, and is highly cost effective. So, vitamin D deficiency induces disorders are common, multiple disorders, and they are preventable with a very low cost maneuvers. With reference to COVID-19, the adequate vitamin D levels prevent COVID-19 related complications and indeed deaths. Then why not? Thank you. We'll have time for questions, and the moderator, I think Dr. Mahavitangi, is going to ask questions, and we'll take as much as questions possible given the time limitation. Thank you for participation, and we would like to welcome you back in another Zoom session in the future with a slightly different topic as things are moving ahead and the second wave is halfway through, and the vaccines are coming in the market, and things can change. So we'll have another meeting, Zoom meeting on the different topics in future. Please join us there. Have a great day. So this slide summarizes some of our activities, what we work through the charitable foundation called Wimalawansa Foundation. And anyone's interested in joining us to help people, the needy and the poor, you're welcome to join us through any of these means. Thank you again.
Thank you very much, Professor Sunil Wimalawansa, for that excellent presentation. With that, let us open the floor for discussions and comments. I have got a list of questions, so I will be posting them to Professor Sunil Wimalawansa as they come. Professor Sunil Wimalawansa, one of the questions that I have received through the chat box is that you talk about vitamin D, and we are living in a tropical country, so there is ample amount of, we are exposed to sunshine. So do we really need to worry about vitamin D content in our bodies?
Dr. Mahathir, it's an excellent question. I'll answer that on three different parts, I guess. So there's no part of the world one would immune from getting vitamin D deficiency. So let me explain that. In fact, the vitamin D deficiency is highest when you move away from the equator, like north and the southernmost part of the world. Having said that, around the equator also the vitamin D deficiency is pretty high. In some countries, it's high as 70% of the population. So let me explain why is that. Because although we have the sunshine, the weather conditions are very harsh around the equator, like Middle Eastern countries. Therefore, people do not get exposed to sunlight during their summer period. In fact, it's the opposite of UK and northern part. During summertime, they have the vitamin D deficiency because they just avoid sun totally. And during the winter time, the sun is mild, and therefore they get out and vitamin D deficiency improves. So coming back to tropical countries like in Southeast Asian countries, the issues there is actually traditionally for cultural and cosmetic reasons, people avoid getting exposed to sun, even though sunshine is not that harsh. So in average, whether they avoid the sunshine, they get some exposure to sunlight during the peak time. Therefore, very, very difficult to find people with a severe vitamin D deficiency in tropical countries. In fact, that's one of the key reasons why people are not getting severe complications and death from COVID-19, because people have a certain degree of vitamin D, whether they like it or not. Thank you.
That leads to my next question, sir. If we are to get the maximum out from the sunlight, is there a particular time that we should get ourselves exposed?
Answer to your question is absolutely yes. The reason is the sun rays need to be in an acute angle to penetrate your skin or my skin. So having said that, that's between 10:30 in the morning and 1:30 p.m. in the afternoon. During that 2-hour period, 2.5-hour period, the sun rays is able to penetrate the skin to the dermis so that it can react to convert the 7-dehydroxy cholesterol to pre-vitamin D. So that's the scientific reason behind. So timing is very important. Two things. Firstly, before 9 a.m. and after 3:30 p.m., very, very little vitamin D you can produce through the skin. Exactly the same thing applies to during the winter period in northern and southern latitude countries. They produce virtually zero vitamin D, even though they can spend 3 hours in sunlight. Because the same principle.
So, Professor Wimalawansa, a country like ours is concerned, what is the best duration that one should get himself or herself into the exposed to sunlight?
So that also gave me opportunity to ask another question. A lot of people ask me whether the timing which I mentioned from 10:30 to 1:30, whether it's different from different countries. Absolutely not. Whether you live in UK, USA, Sri Lanka, Australia, the timing is the timing for the country where the sun is on at the peak. I give another clue, very easy thing to remember. When you go out at say 11:30 in the morning, if your shadow should be less than your height. So that's a good clue and very easy to find. If your shadow is taller than you, then that sunlight will not be able to penetrate your skin. So coming back to your question, the places like Sri Lanka and India, for example, the duration of staying in the sunshine depending on the melanin content, in other words, the darkness of your skin. Darker your skin, it acts as a barrier to ultraviolet ray penetration to the dermis to produce vitamin D. So darker your skin, the duration you need to stay in the sunshine increases. It will be examples so that you understand well. So that in Sri Lanka, for example, the white person and a dark person stay in the sunshine for say 1 hour, the whiter person will produce 6 times more vitamin D than the darker person. So that means that the brown and the darker skin person need to stay the minimum of 30 minutes, preferably more than that on a daily basis under the sun to have the maximum benefit.
With that, there's another question just appeared, sir. So that means on average, if you consider an average person in country like Sri Lanka or India, exposure to sunlight 30 minutes a day would sufficient to produce the recommended amount of vitamin D?
Okay, again, it's an excellent question. I generally say that the 30 minutes is reasonable for Sri Lankans because Sri Lankans the skins are not dark as the West Indies and other African countries. For them, if we are talking about the 1.5 hours to 2 hours in sunshine, it's very difficult. The Sri Lankan average skin, the melanin content is what I call the Fitzpatrick level 3 or so. It's right in the middle. So 30 minutes will, on average, can generate anything from 800 to 2,500 international units of vitamin D, provided that if you have a 1/3 of the body's skin surface area is exposed to sunlight.
So the next question that I want to ask you before we move into the COVID and vitamin D is that apart from the exposure to sunlight, what are the other potential sources of vitamin D?
All right, so let me answer your question. I need to add something after that. So the problem is you can have the very balanced diet, nutritious, and still become vitamin D deficient. So it's surprising for some people. I'm getting the best diet on the earth. I am still vitamin D deficient. The reason is a diet provided us with very, very little vitamin D. In fact, that most of the vegetables and the cereals and things give no vitamin D. Only vegetable can provide the reasonable amount is sun exposed mushroom. It's critically important. The sun mushrooms, before you cook, you need to put upside down and put in the sunshine for a couple of hours. Then you can increase the vitamin D content by about 4 to 5 times. Still, you're talking about 800 to 1,000 units per 100 grams of mushroom, not much. The other source of vitamin D is any fatty fish, like mackerel, sardine, salmon, tuna. So those fatty fish also have the natural D3 they produce and store in their fat mostly. So other than that, there's virtually no other food can actually provide vitamin D sufficiently, except in a given country, the milk and cereal and breakfast cereal and things are also fortified with vitamin D. That's a good source of regular intake of vitamin D.
Professor Wimalawansa, you talk about two types of vitamin Ds in your presentation, vitamin D2 and D3. Do you see a vast difference in these two or both are equal?
Until about 15 to 20 years ago, we believed that D2 is equivalent to D3. Now, with the latest data, especially the pharmacodynamic data and bioavailability, we know that that's not true. In fact, as you saw the early part of the lecture, I produced the structure of the D2 and D3. Please go back and review. They are slightly different. So the major difference between the two are D2 half-life in the circulation and tissues is lower, almost 50% lower. And therefore, it does not remaining in the system, body system for that amount of duration. Secondly, D2 is come from the plant sources exclusively. D3 is from the fish and also the natural source of is D3. Receptor point of view, biochemically, in the potency to the acid travel to vitamin D receptor affinity is the same though. However, if the chemical is not lasting that long in the blood, so naturally the potency over a period, what you call the area under the curve, will be less with vitamin D, D2. So the preferred source for supplementation is a D3.
So, in other words, what you are referring is that the D3 is likely to be the most effective form of vitamin D source.
Yes, it is a natural hormonal form of a human. There's one caveat. There are people, the vegans, or they may not like even the vitamin D capsules made of gelatin, for example. So then you can have the gelatin capsule made up of totally algae and things like that on D2. They're really particular about D2, then they can take D2, but at almost twice the dose than recommended.
The other, before I move into the other question, which is basically the COVID and vitamin D, I would like to know, Professor Wimalawansa, your opinion about the current pandemic of COVID and the measures to prevent it, like even the vaccine or even the social distancing. Do you see that even a vaccine alone will help us to control this COVID-19 pandemic?
Thank you, but you're asking to give me a lecture for another 90 minutes. So the issue with multiple issues. It's kind of misleading to say that to adhering to all the standard public health measures is adequate to control vitamin D. It is not. There are two reasons for it. Firstly, most of the infections are occurring through asymptomatic carriers. So we cannot detect those asymptomatic carriers in the community unless the government or health department is doing the community-based testing. Sri Lanka, for example, did zero community testing till mid-October 2020. So they missed 95% of the people who was infected in the community, and therefore they remained spreading the disease. That's why it became communities, multiple community clusters. So the second part is actually even if you get in the disease, the people with a certain amount of immunity get a very mild disorder, just like common cold or flu. So the diagnosis of this group of people who still can spread the disease is difficult unless you do the proper testing.
So in terms of the other remedies like a vaccine, what is your opinion about, will it be able to control the pandemic fully, or do we still need some other measures?
All right. So again, I'm going to ask the hypothetical question before and then ask your question. Currently, in fact, there are only three agents who can be effective in prevention and treatment of COVID-19. Prevention point of view, the vitamin D is the only effective option for prevention of the disease and prevention of the complication. Early stage of the disease and also to a part prevention, hydroxychloroquine at the right doses, the right duration can have a major effect on controlling symptomatology and complication, prevention of complication. Third group of drug, the medication that has been shown to have an effect is a dexamethasone, which is a very, very potent glucocorticoid agent. But however, this is only indicated in about 4% or less than 5% of the people admitted to the intensive care unit with the respiratory and other difficulties and complications. Only in this group ever the hydrocortisone or dexamethasone should be administered, and if administered properly, it might be able to prevent the what we call it's a cytokine storms and damaging acute lung injury and death. Whereas if you administer glucocorticoids or dexamethasone for somebody with a milder or moderate disease, you can actually make them much worse, and you can actually create complication and death on those patients. So you need to use the medication very, very carefully in the selected patients to do that. So let me answer the question of the vaccine. To date, there never had been a good, safe, and effective vaccine for any coronavirus disorders, basically RNA viruses. And experts had been estimated written that usually take about 5 to 7 years to develop such vaccine, because you need to have a safety precaution, multiple levels of testing to be done properly. Unfortunately, because of the competition and the greed of pharmaceutical agencies, they have cut short that to 6 months. So you understand that anything cut short to that dramatically from 7 years or 6 years to 6 months, you are going to have problems. In fact, some of the vaccines tested in Brazil, for example, there had been deaths, and nobody wants to talk about it. So I think that jumping into the vaccine bandwagon is too premature, and will have a significant negative effects on future generations to come.
So now you have clearly highlighted in your presentation the existing evidence of effectiveness of vitamin D in the prevention of COVID-19 infections. Now, my question is that if that is the case, why not any government, even in any industry, has not actually taken up the point and driving this towards coming up with another supplementation regime or something like that?
Thank you. I mentioned the name of the drug called hydroxyquinoline, which had been used for almost 70 years to control malaria, and recent days have been very successfully used for rheumatoid arthritis and other immune abnormality related disorders, very successfully. It's the adverse effects is due to cardiac arrhythmias. It's exceptionally rare. I can't remember the exact incident. It's something like 1 in 8,000 people can develop cardiac arrhythmias or prolonged QT syndrome, which automatically subsides once you stop the drug. So it's a very safe drug, so as vitamin D. Issue is actually both these medications are exceptionally cheap. We are talking about in dollars per se, we are talking about a $2, $3, $4 maximum for a course of treatment with this medication. Compared to antiviral, like what's available now, you're talking about a few $10,000 to $50,000 worth of expenses. Same with the antiviral vaccines, going to be cost quite few because they need to be given repeatedly. So as you see that there is a conflict of interests of not only from the industry, but mostly from the investors and the politician, basically, to generate more funding and money using the expensive modes of treatment. In fact, they are not even tried properly and approved for safety, rather than using the already available, very tested things like vitamin D and hydroxyquinoline. They are very safe and exceptionally cheap to use.
So in that context, Professor Wimalawansa, what is the most safest therapeutic dose of vitamin D in prevention of infectious diseases?
So there's nothing called the dose for COVID-19. That's because everybody is different with the starting level. The issue is people who come into the intensive care units and dying of COVID, virtually 99% of them had the severe vitamin D deficiency. I'm talking about the levels less than 10 nanograms per mil. The exceptionally low level of vitamin D. So they don't have the innate immune system to fight against the invading pathogens. including the viruses like COVID-19. So we need to break that vicious cycle by increasing not only the individual vitamin D status, but also population vitamin D status. That must be the strategy to prevent COVID-19 from any given country. We had that opportunity in March, I proposed, but no one was interested in Sri Lanka to do that. If you do that and increase the population vitamin D level above 30 nanograms per mil, entire adult population actually age from 10 and above, there's no reason whatsoever to have a lockdowns, curfew, or any economic restriction. You should have managed the country as nothing has happened. Because no one is going to get sick and no one is going to need hospital administration. There's no need to prepare 5,000, 6,000 beds on quarantine centers. Absolutely no need to expand intensive care unit. Yet administrators and politicians doesn't seem to be understand or doesn't want to understand the safe and already available mode of prevention of COVID-19.
So, Professor Wimalawansa, you are basically recommending a mass-scale vitamin D supplementation program. So the last question is, now we know that the vitamin D is not a water-soluble vitamin and can cause toxicity if you take a very high dose. So how do you ensure the safety of such a supplementation program?
So I forgot to answer the second part of the previous question. You asked me the average dose. Average dose to maintain a serum level above 30 to 40 nanograms per mil is about 4,000 international units per person. In normal
per day, sir.
4,000 international units per day orally. And normal, in the absence of COVID-19, the average doses need for population is between 1,000 and 4,000 international units. The problem is the COVID complication and death occur in people with multiple comorbid conditions like diabetes, hypertension, kidney failure, those kind of things. So to control those comorbid conditions, most of them need about 40 nanograms per mil in the blood for circulation to overcome that. Because of that, we in the academia, we recommend that to keep the vitamin D level above 40 nanograms per mil. In other words, a range between 40 to 60 nanograms per mil is the most effective of doing that. Second issue is somebody come on an emergency situation to a hospital or a general practitioner with signs and symptoms of some exposure to vitamin D. You need to boost their immune system immediately within a day or two. So giving 4,000 units vitamin D will not touch. It takes 90 days to actually raise the blood level. In those situations, I urge the physicians and the practicing physicians and healthcare workers to prescribe and give them a high dose vitamin D upfront. What we and the most global physicians are using is a dose of between 100,000 and 400,000 as either stat dose or given on a daily basis, something like 50,000 units for the next 5 days or something like that. So what we are doing here actually give a high dose upfront, not only to raise blood levels, but also start boosting the immune system. You should take about 2 to 3 days to do that. So that difference is very important to remember. So 4,000 is a maintenance dose, whereas you need to boost your system quickly as possible using the high dose upfront loading dose. Sanat, can you summarize the last question?
The last question is that now if we are to go for an mass scale vitamin D supplementation program, knowing the fact that vitamin D is not a water soluble vitamin, how do we ensure that there will not be toxicity and there are other side effects of vitamin D higher doses?
Actually, it's a myth that vitamin D is essential to have water soluble. Yes and no. So when you take the oral vitamin D, it's always better to take with a little bit of fatty contain, something to do with the fat. So it definitely enhances absorption. Having said that, vitamin D also available as a powder in the water-soluble form that can be dissolved in water and give the appropriate amount. So that's why I said the yes and no on that. So second part of the important part of the question is to get toxicity from vitamin D, any form. you're going to require getting the blood levels above 150 nanograms per mil. That is about 350 nanomoles per liter, huge level. To achieve such, you need to take millions of units of vitamin D, not 200,000-300,000. They won't even touch. So that because of that, the incidence of vitamin D toxicity exceptionally rare, and in the community is something like 1 in 100,000 or less. So you can see that how rare it is, vitamin D toxicity. And most of the reported toxicity due to vitamin D is either taken deliberately as poison, or they forgot to read the label and taken very high doses. For example, in Canada, some time ago, there was preparation. Each drop was a 1 million unit. So this was given to children with unknowingly that it forgottenly they assume that it's about 1,000 international unit, but actual dose of 1 million. So, but a dozen of kids got toxic pretty quickly, taking 10 million or higher doses of vitamin D. So I don't think people listening to this, watching this, need to be worried about vitamin D toxicity, because the recommended doses will never achieve that kind of higher blood level of vitamin D.
Thank you very much, Professor Sunil Wimalawansa. That ends the time allocated for question and answer session. Before we conclude, I really wanted to thank all the participants for their patience, because today's webinar is a great success. We have nearly 80 participants attending all around the world today. So also I would like to thank Professor Sunil Wimalawansa joining with us today on behalf of the College of Biochemistry Lanka. And we will meet you again in another monthly webinar. Thank you very much.